right here today. We have Dr. McIntyre, Dr. Tina Bakanker, and there's Dr. Tina and Dr. Morey. They're joining us and will be helping through the sessions today. So with that, I'll pass it on to our course directors to open the course. Thank you.
Great. I wanted to welcome you all. First, I always want to start by really acknowledging Medtronic and its leadership for medical education. We recognize this is a very important part of the lives of education of our fellows, cardiology and EP fellows, and really feel it's critical, and Medtronic plays a really critical role. So thank you to Medtronic. Andrew and I are really, really honored and delighted to be course directors for this really terrific program. We really pride ourselves that, this is meant to be personal. So we're here throughout the entire program. We're here at breaks. We're here, throughout the whole program. So we really want to get to you know personally. We want you to feel you can come up to us and ask questions. That's the whole purpose of this. One of the unique things that you heard about is the one-on-ones that we're trying to do. So give a little, again, more personal touch to the program. And then the crazy thing, when we have new faculty that come through and they just think that we misspoke because I said, no, you're not going to give your talk once. You're going to give your talk 3 or 4 times. And so that's, as you'll see, that's in the session. So we will be rotating through these breakouts, and the faculty are moving. You'll stay in one place, and we move from one room to the next and give the, kind of the same talk over and over again. And we do that very, intentionally, because what we want to do is keep the group small so that we can reach out to you and answer your questions. So we think that's a really unique. We don't know of any other programs that do that, frankly. So that's our goal, and we think that is really well suited to our topic. Devices are something you need to kind of work through, and it really helps to be able to sit down and kind of feel like, wow, I really worked through that problem. And the best way to do that is in a small group and going through cases, et cetera. So we hope that you'll find it to be, really as impactful as we really want it to be. So with that, I'm going to turn things over to Dr. Russo and for her additional comments.
Thank you. Thank you, Medtronic is really, and thank you, Ishita, and team who have really put in just an incredible amount of effort to make this course work every year. It's really an honor to have joined, Paul as co-director last year. This is unique. This is a unique experience, and is one of my favorite, courses, because we really do have in the smaller group. I think in person is going to be even more fun than it was over virtual, getting to know people. So please, spend the time with each of us, 10 or 15 minutes during those allotted times. And then it's really a way for us to get to know you in a unique experience. So thank you, again for coming in person. We do have a virtual audience, but please encourage everyone to ask questions, and any kind of questions. We have some didactic type of format here, but for most of it's case presentations, troubleshooting, looking at electrograms, looking at x-rays, things like that. That's kind of really a different kind of course than many others. So welcome, and I look forward to meeting everyone personally. And I think I'm first on. So I am going to talk about evidence-based programming. And, a lot of things that we do in medicine are evidence-based, right? We have guidelines now. We have consensus documents. We'll have a new guideline document for, pacemakers and coming out shortly. So we really, we want to see how that's implemented in clinical practice. And sometimes there is a lag, but there is data, and there's some really good data in this field. So I'm going to and I'm not going to talk about everything that's evidence-based. There's more to it, but I'm going to try to highlight some of the more important issues. Conflicts obviously are many related to device consultation and also being here as part of the course director. So I'm going to start out with some evidence-based tachy detection and therapy, evidence-based therapies, and also mention a little bit about bradycardia and a little bit about CRT, just some of the major high-level high points of that. So, starting out again, I always think it's nice to put things into a kind of case presentation. I won't call on anyone unless no one yells out, but yell out. I have like 3 questions actually through this talk, but 75-year-old comes with a non-ischemic cardiomyopathy, has had heart failure, had an ICD implanted for primary prevention indication. EF was low, but then got better, is on medical therapy, including a beta blocker, low-dose beta blocker, 25 milligrams a day of metoprolol, and receives an ICD shock for that rhythm. Let me see if I can use a pointer here or not. That may or may not work, but you could see the, yeah, there it is. Okay, so here is the atrial electrogram and the ventricular electrogram. You can see this looks like atrial fibrillation, irregular ventricular rate, and the marker channels, which are probably hard to see from the back, are noted on the bottom. So, the patient has never received any prior therapy as a primary prevention device, and the way this particular device was programmed is with perhaps it was an out-of-box setting for this particular device at 165 beats a minute. VF was set at 195 with a detection duration of 2.5 seconds. So the different manufacturers, do their duration in either number of intervals to detect NID or in seconds, and this one is in seconds, 2.5. And then the rate you can see in AFib gets pretty fast, 143 to 212 beats a minute in millisecond conversion. So in addition, you're going to increase the metoprolol, you're going to start anticoagulation. What else would you recommend next, at least initially? Do you program the VF detection up to 222 and just put a monitor zone on at 170? Maybe the device was programmed pretty low to begin with. Do you turn off stability? Do you shorten the detection duration, or just don't do any other programming changes? Any thoughts? Anyone? People are whispering, but I can't hear. Right, so you're going to change the detection, right? You're going to put it up at a faster rate. Maybe you won't leave it there forever, but you're going to put it faster than it was before, and you'll see based on evidence-based programming, really 165 is pretty low for someone who has never had a ventricular arrhythmia. And we know that inappropriate shocks can occur in a lot of patients. Even our clinical trials, things like Scud-Heft, about a third of patients, about a third of shocks were inappropriate, and many patients received inappropriate therapy in many of these trials. And usually inappropriate therapy in the majority of cases is for atrial arrhythmias. This case was atrial fibrillation. Sinus tach, particularly young, active people can have defibrillator therapy for sinus tachycardia. And then we call it really not just inappropriate, but unnecessary therapy. We have to give it some time. Initially with devices when they weren't very good or when they were first developed and may not have as effective therapy, we wanted to treat very, very quickly. But now we don't want to treat an arrhythmia that will probably stop. So non-sustained self-terminating arrhythmias, there's no reason to treat that. And we can only make things worse if it's going to stop. Oversensing of intracardiac signals, things like T waves, double counting of the QRS, P waves, again, less likely now to have a separately implanted pacemaker, except for maybe a subcutaneous or a non-vascular device. Oversensing of extracardiac signals like diaphragmatic oversensing, EMI, things like electrocautery or noise or artifact for other reasons like lead fracture. And, shocks are not fun, right? It's painful, reduces quality of life, could be pro-arrhythmic. So ICD pro-arrhythmia, you start out with nice monomorphic VT. If it's a shock that doesn't work, you can go, have the arrhythmia go to VF, or even worse than that, go from, AFib potentially to a ventricular arrhythmia. If you get a lot of shocks or aborted shocks, it could potentially affect the battery. You can worsen heart failure and use healthcare resources. We pay attention to that. And then there was always the question, does it really affect mortality? Well, this is just one of the studies looking, this was from Scud-Heft, looking at the association, and that's what it is, an association between shocks and the risk of death in Scud-Heft. You could see that 33% received at least one shock in the study, and you could see that both appropriate as well as because inappropriate shocks were associated with increased mortality. Now, in these patients, the cause of death was most likely progressive heart failure. So, it's one of those things, the chicken or the egg, is the patient getting sick and the substrate's getting worse, and you're seeing therapy because they're having arrhythmias, and it's just not a cause and effect. So it's really not the way we should think of it. We want to deliver therapy when we need it and not deliver it when we don't need it. So how can we reduce shock? So the general concept of looking at programming considerations, programming for detection, lots of evidence-based studies looking at that, as well as therapy. And some of the very basics we see is we're looking at the number of zones. And here you see a VF zone, a fast VT, and a VT zone. The detection duration, or in this case, it's the number of intervals to detect. And this is for the VF zone, it's any number out of the total number there. So, 24, doesn't have to be 24 in a row, but the VT zone would be, 16 or however you program it, in a row to be detected there. The rate cut off in each zone, so you get to pick that. And so what does the evidence show for primary prevention or secondary prevention? What should we be setting that at routinely? And then you want to deliver anti-tachycardia pacing in the therapies, right? So you want to give some painless therapy. And what is the data related to that? And we'll talk more, I think it's tomorrow, we have a talk on ATP in more detail. So you want to set it, and you want to set SVT discriminators, and we have many. And so we want to withhold unnecessary therapy. So if we have SVT, we don't want to deliver therapy for that. And I do want to mention, because I think some people do, and it's worded differently on that first, the other manufacturer's slide I showed earlier, it was worded differently, but this is timeout, right? So if you turn, I never really turn that on, because if you turn it on, you're saying, I don't believe the device is good enough to distinguish SVT from VT, because if you time it out at 30 seconds, you're going to get shocked, after 30 seconds if it still meets the rate cut criteria. So very rarely would you want to turn that on. A sudden onset, things like, is it sinus tachycardia that comes on gradually? The device will, calculate the difference between, the current beat compared to the last beats. Is it more like, VTAC that starts suddenly, or SVT can start suddenly also. Stability means, is it regular or irregular, and how irregular is it? And you can put that number in, in milliseconds, 40 milliseconds, 45, or whatever you want, if you want to program that on. Morphology or wavelet, how much does that intracardiac electrogram look like the one that was in sinus rhythm or your intrinsic rhythm? And then there's also all these really great, dual chamber. So if you have a dual chamber device, you have additional dual chamber discriminators. And then you want therapy for fast VTs. So, we used to think, we were just going to shock if the rhythm is, like, for example, over 200 beats a minute. But now there's, we have ATP even in the, VF zone. It may not be VF, it may be a rapid VT, and that falls in the VF zone, that you want to deliver painless therapy first to see if you could terminate the arrhythmia. This is just an example of where the device appropriately used wavelet, and in this case, and each manufacturer has their own, algorithm for how it looks at this and counts beats. But if you have at least 3 of them that match, it'll withhold therapy. So if it's 70% or more in this case, it matches the stored, signal. It's going to say it's SVT. I don't want to treat that as VTAC. I'm going to withhold therapy. And then for dual chamber devices, there's a whole variety of different dual chamber discriminators. It'll analyze the relationship between the atrial and the ventricular electrograms, and also, look at, other things after doing that. So do you have AV dissociation? Are there more V's than A's, as shown here? Is the A equal to the V rate, or you have more A's than V's? And then it uses other criteria for discrimination in addition. So what is the evidence? And we have a lot of evidence. I think it's worth going through some of that so you understand where our guidelines, our consensus document and guidelines come from. So if this was one of the earlier studies called Pain Free, and you have to remember too, each of these studies was done with different manufacturers' devices. This was a Medtronic study looking at over 600 patients, and showed that in many cases you have fast VTs that represented 76% of all episodes that were less than 350 millisecond, 20 milliseconds, so 188 beats per minute. They were faster than that. So that would have been, if you didn't have ATP on, people would have gotten shocked for that, right? So, but ATP was successful in 72% of cases. So even fast VT, we could pace out, like we do in the EP lab. If we're inducing VT, we can pace out a fast VT. The device does that also. And then there's, I won't go through all the details in all these studies, but mention some. A variety of studies, both randomized as well as observational studies with a large number of patients overall, that looked at the different criteria, rate cutoffs, different rate cutoffs, different detection durations, number to intervals to treat or in seconds, ATP in the fast VT zone or in the VF zone in some cases, monitor zone, do you turn one on or not? So this was one of the earlier studies, Prepare. This used a historical control, but, at the time, they were looking specifically at setting a VT-VF rate of 182 beats per minute, but using 30 out of 40. And at the time we thought, we had is that going to be safe or not? We didn't know that 30 out of 40 would be good, to still be safe. And well, that was what the study showed. And also giving ATP therapy first for regular rhythms, if the rates are between 182 and 250. So that's how you could avoid, to avoid any therapy for slower arrhythmias, setting the rate cutoff not at 165 in our case, but setting it at 182 here. 30 out of 40 to reduce the chance that you'll get therapy for self-terminating arrhythmias like non-sustained VT, and then putting on the burst sequences. And so overall, the results were shocked episodes were reduced by 63%. And in fact, only 3.8% of patients received inappropriate therapy in this study. And this included a reduction in therapy for both appropriate things, they're in red, this is compared to the historical control, as well as for inappropriate therapy. So you reduced both appropriate and inappropriate. Appropriate meaning VTAC, but that VTAC might have terminated spontaneously. Then you had a large randomized trial. This is with a different manufacturer's device, but still the concept is the same, setting up 3 different options and randomizing. These are either dual or CRT devices, primary prevention again. Setting up a VT zone is standard at the time. We were setting 170 beats a minute or something around that for VT and 200 for VF. That was considered standard programming. The high rate cutoff was 200 beats per minute with just a monitor zone at 170. So don't treat unless it's really fast. You're getting this device for primary prevention. And then a very long delay of actually 60 seconds in the zone 1, the VT zone. In the second VT zone, the delay was 12 seconds at 200 beats a minute detection. And for 250 beats per minute, it was a 2.5 delay. So that was called the long delay zone. And then the other one was the high rate zone. Those are the 2 non-standard zones. And then the study showed pretty clearly significant difference. You could see conventional therapy, time to inappropriate shock therapy, much better with either delayed therapy or high rate therapy compared to conventional therapy, statistically significant. And not only that, and I think this may have been somewhat of a surprise, is that you can actually improve outcome in terms of mortality. So those hard outcomes, not just shocks, but you can improve overall mortality. And it was a significant difference when you compared the high rate cutoff versus conventional therapy. Not quite significant for the long detection, but pretty close. Advance 3 was another study. Now, this one included not just primary prevention, also secondary prevention patients. They were randomized to a long detection delay, 30 out of 40 intervals, with ATP during charging versus standard detection at the time was 18 out of 24. And you could see here that it favored the 30 out of 40 intervals and ATP during charging group compared to standard programming in terms of reducing inappropriate therapy. And time to inappropriate shock was also delayed in this group. And then this held true. This is not just for, for multi, leads, not just dual chamber and CRT, but would also be true for single chamber devices. So we should be programming those the same because there's similar results. Improves the time to get appropriate and inappropriate therapy, very significant, right? Difference between the red line and the blue line there. And survival was also improved. And that was significant even for the single chamber devices. This is a more recent study. This is also with Medtronic devices, pain-free SST, smart shock technology. So if you notice, like on the current devices, you have not just all these discriminators and rate cutoffs and all these other number of intervals to detect, but you also have these what is being referred to as modern programming strategies. So there's things like novel discrimination, things like T-wave oversensing algorithm, lead noise. The engineers are very smart. They can have the device be able to detect what's the difference between noise and other things. RV integrity alert, and including all those different features in there too. And there was also a randomized part for the secondary prevention patients, which I'll show you after this. But you could see here, extremely low rate with this kind of programming, extremely low rate of inappropriate shock therapy at 1 year. Only 1.5% with dual chamber devices or CRT devices, 2.5% with single chamber devices. And most commonly, when you had an inappropriate shock, it was due to atrial arrhythmias. So this novel enhanced detection, improves things even more. And then looking specifically at those secondary prevention patients, because there was a paucity of data in that regard, this was randomized to either standard programming of 18 out of 24, because people may be more worried about, people have already had sustained arrhythmias. And that was, we were concerned, would this be appropriate for programming for the 30 out of 40 appropriate for them? And then it's still using all these other enhanced features on either of those programming options, 18 out of 24 versus prolonged detection at 30 out of 40. You could see here too, time to the first episode of arrhythmic syncope was not different. So you worried that patients may pass out because they already have a sustained arrhythmia before, but no difference between the groups. Now, by the way, there was no difference in time to appropriate or inappropriate therapy between the groups. So overall, and then all-cause mortality, although I think that doesn't quite reach statistical significance there, they're still pretty much you're getting it's close, and if anything, it's the shorter duration, is doing worse. So it's safe. Basically, bottom line, it's safe to program that out to 30 out of 40, even for your secondary prevention patients. So everyone, puts this, any topic, right? Someone's going to write this, the meta-analysis of this and appropriate shocks. This is not incorporating the last study, but you could see, again, incorporating all the studies together, using this therapy reduction strategies is favored in terms of reducing inappropriate shocks. And if you look at mortality, again, a significant difference, reduced mortality if you program on all these enhancements and therapy reduction strategies with no significant difference in syncope. So you don't have to worry about adverse effects. So, back in 2015, several of us put together part of this, consensus document, and incorporates basically the evidence, just like we have guidelines for everything else we do, beta blockers and ACE inhibitors and all these other kind of things. We have guidelines for programming devices. And for primary prevention, and most of these studies were published by the time this document came out. It says, program a prolonged detection duration, either the 30 intervals, with the Medtronic studies, or 6 to 12 seconds, for some of the other manufacturers. And, you should also not program it too low. Don't put it at 165 beats a minute for primary prevention. Put the slower tachycardia therapy zone at 185 to 200, somewhere in there, depending on what study you look at. Secondary prevention, again, it's still safe for those patients, even more evidence now for that. So maybe that'll get a higher level of recommendation. It was a class 1 recommendation. It was a BR before. And for secondary prevention, if you already know you have monomorphic VT that's slow, you want to make sure you're detecting that so you can give yourself a little leeway, at least 10 beats per minute below the tachycardia rate that you know of if you're not ablating that VT. And then also saying you can give ATP therapy, even for fast VT. So you can give ATP for fast VT zone or in the VF zone, and you could deliver at least one ATP attempt. We'll talk more about ATP and how many attempts you might deliver tomorrow. But again, you're gonna still take care of your patient, right? And every patient we look at differently. You're gonna individualize the programming. If you have a young patient who's active hypertrophic cardiomyopathy, they're running all the time, have really good AV nodes, you're gonna wanna make sure that you put that rate cutoff really high. And some of those patients, you might even do a stress test to see how high they can get their rate, but you might wanna have them on AV nodal blocking drugs. They might not like it too much, but at least don't shock them or have a chance to shock them for sinus tach. If they have known atrial arrhythmias, you want to treat those arrhythmias. You want to take that into account. A slow VT, you might, if it's going to overlap with those atrial arrhythmias in particular, you could ablate the VT too. So you got to consider the particular patient too. There's also, sometimes we've seen trouble with T-wave oversensing. This is just seeing, not only intermittently you're detecting the T-wave, and you can see it's a big T wave in this case, and you're counting that. So this one didn't get therapy, but there are, in the Medtronic devices, you do have this, T wave oversensing algorithm that you can see that looks different to our eye, and the engineers figure out how to make the device not see that, right? And in noise, the same thing is there's these, detection, there's lead alerts also to give you a warning. You can see here, this is a fracture of a lead. Lots of noise there. You're detecting it. If it stops soon enough, you sometimes, you won't get therapy. But you can see you have a lot of warning, and we're going to hear tomorrow, either tomorrow or Sunday, more about the role of remote monitoring, and that's really key because you could pick this up. This shouldn't have gone on this long, right? You should have been seeing it in here. And lead alerts would also help with that, to get to that patient before they get shocked. And actually, the other side effect of prolonging the detection duration to 30 out of 40, Chuck Swerdlow actually has published a lot in this field of detection algorithms, but you could see less likely to get therapy for these noise kind of things if you had that programmed on than if you had these short detections, which makes sense because a lot of that noise may be when patients are moving their arm, and they may not be moving their arm. That causes noise for a long period of time. So the longer the number of beats that you need, the more beats you need, chances are you might not get a shock. You might get an aborted shock, but at least you don't get shocked. So incorporating into the consensus document, into the recommendations, again, activate the lead failure alerts, activate the noise algorithm, and activate the T-wave oversensing algorithm if the manufacturer has these different things available. Now, the SICD is completely different. You don't have all these different options for programming, right? But you have some. And I would say I think people are probably less aware of these. So you either program on, you just have a shock zone and a conditional zone. So you should always program on with this manufacturer's device the conditional zone, because even though you don't get anti-tachycardia pacing, there's no pacing with this device except for a brief post-shock pacing because it's all subcutaneous. There's nothing to do ATP with. You can't do that because that would be painful. But program on the conditional zone because you'll still use discriminators in that zone. And there's some data to support that. So as I showed or alluded to, a lot of our trials had a lot of inappropriate therapy at the time, similar timing. The IDE trial for the subcutaneous ICD also had, that's in the orange bar here, also had a lot of inappropriate therapy. However, the reason for inappropriate therapy is different. More often with the SICD, you get it for T-wave oversensing. And so you can see you're double counting the QRS and the T-wave here. So in fact, if you look at, this was a meta-analysis of case-controlled studies, a lot of patients all together. So if you look at inappropriate therapy overall between the subcutaneous device when this study was published in 2020, you could see that overall inappropriate shocks were similar, number of events, with sub-Q ICD and transvenous. However, the reason for inappropriate shocks with the transvenous device overall in the meta-analysis was more often due to SVT, things like AFib, and it was more due to oversensing, mostly T-wave oversensing, but other extracardiac oversensing with the sub-Q ICD. So the reason for inappropriate shocks is different. And this shows that if you program on that conditional zone, you don't, totally get rid of it, but you can reduce inappropriate therapy for SVT as well as oversensing by a significant degree. There's also, they have another thing they have now, is a smart pass filter that should be programmed on now out of box in their devices, but that should always be programmed on to help reduce this cardiac oversensing. And again, the guidelines, the consensus document, the consensus statement says that you should program on with the SICD to tachycardia detection zone. So that's based on the evidence, based on the data. So do we do it? Well, as with our guidelines, there's always a lag in guidelines. We have all these randomized trials. We have a lot of data. We have consensus document. So after made it RIT, there was a bump in the, evidence-based programming. And then after, the consensus document, there was a further, increase of, uptake of some of these or some of the features. Some people program on some more than others, but we're not perfect, right? And so it all depends on how things work, who's following them, who's implanting the devices, and who's, programming right after, because often, the devices may stay, not every device is followed by an EP doc, right? So they often may stay at whatever they leave the hospital on. So I try to make an effort, if I know, all the time, make an effort to program them with evidence-based programming when they leave the hospital, especially if a general cardiologist is following the patient. You want to be able to, and now out-of-box settings. So, the device manufacturers, if the studies were done, whatever the FDA approved it with, they can't just suddenly change. A study comes out, now we change our out-of-box settings. They can't do that overnight. So there will be some lag before the out-of-box settings get changed. So should everyone have evidence-based programming? I'd say, well, for primary prevention indications, it's about 80% of devices are implanted for primary prevention. Most, not every single person, nothing is ever everyone, right? Should have evidence-based programming, and now we have some data for secondary prevention without increasing risk in most patients. But we have to have common sense. There's individual patients, and we may program some people differently. Dr. Swerdlow and others did publish some, there was some cases of being reported, evidence-based programming may not always apply. So if you're using a study from one manufacturer and you throw it into a pot and you program, they're not all the same, right? Each of the algorithms are a little different. So if you're using a device and you're using a study that used Medtronic devices, that's easy because then you're using the same manufacturer. But what we had initially done is published an online supplement of so all the manufacturers looked at this and said, how does this guideline or this consensus statement apply to your device? And they would say, because how do you translate 30 out of 40 to seconds? I mean, it's not easy to figure that out, right? So the manufacturers would figure it out. And so that's published. And so now it's actually not just an online format, that's actually published in Heart Rhythm. So people could look that up if they want to apply to what another device company from a study. I'm going to just briefly mention in the next 10 minutes or so a little bit about some of the other evidence-based programming that was also discussed in the consensus document and other studies, and bradycardia just highlighting one thing in particular by a case. A 72-year-old ischemic cardiomyopathy and had an ICD for primary prevention, now has worsening heart failure. EF is actually decreased from 30 down to 20. He's on guideline-directed medical therapy, followed by a heart failure doc. They maximized it, but the EF is low. Coronaries and everything with patent stent all looks okay. But what we notice is we see here's the programming, and it looks like it's pretty decent. I don't know why they're at 70 beats a minute, but they're programming some reasonable therapies. Here it's a monitor zone and some therapies in here. But what you see here to highlight is now you're pacing about 47% of the time, and they're using MVP, so it's a Medtronic device, and that's managed ventricular pacing to minimize ventricular pacing. So you'll be, you won't conduct, you'll drop a beat, you'll conduct as long as you can, and then you'll drop a beat, and then the device will pace, because it sees a drop beat. So basically you're already doing that. And AFib burden, previously, you don't have any AFib during this interrogation, was about 3%. Average rates were about in the 80s previously. So what do you do next to improve heart failure symptoms? Do you do a pulmonary vein isolation? Do you do an AV junction ablation and make them pace all the time? With this device, do you increase the programmed paced AV delay? Is that going to help? Or do you upgrade them to a CRT device? Any thoughts, or what would you do? CRT upgrade, right? So you've done everything. You've used the algorithms. They're on maximum medical therapy. Programming the AV delay out isn't going to help anyway, because it's, that you already have MVP programmed on here. So that would be the therapy here. So, the concept of reducing, RV pacing is key. And there's, chronic RV pacing is associated with detrimental effects. We increase heart failure risk, we increase the risk of AFib and increase mortality, and the device algorithms could help to reduce this. How many people here are, by the way, I meant to ask, cardiology fellows as opposed to an EP fellow? Do we have? Okay, so we do. So there's a wide variety. So I try to get detailed enough for the EP fellows, but also, and so feel free when we get into the questions period, some of these concepts may not all be as familiar to general cardiology yet. So what's the data? So a lot of this is just showing you the data. Why do we do that? Because we have really good evidence. This was the David trial, and I remember when this was going on, we're thinking, we're going to put dual chamber devices in everyone, even though, most of our primary prevention ICD trials were done with single chamber devices. We're going to make them pace. So we're going to put them DDDR and pace at 70 beats a minute, and we think that's a good thing, right? Well, wrong. In this case, the time you could see here with dual chamber devices compared to VVI backup at 40 beats per minute, the time to hospitalization for new or worsening heart failure was more. It was a shorter time in people who were dual chamber programmed than VVI, and then they tell you too that 59% of the beats in the or RV paced in the dual chamber group, compared to only 3% in the VVI group. So dual chamber pacing was not good. Pacing the RV was not good. And if you divide up, so what percentage of pacing do you need? If you divide that up and you look at people who were paced over 40% of the time, you could see here, those were the people who did worse compared to, if you had dual chamber programming, you still rarely pace, that was okay. Or your VVI pacing and you rarely pace, that's still okay. But, really you don't want to pace more than 40% of the time. MADE 2, again, looking at percentage of RV pacing, and MADE 2, looking at new and worsening heart failure or death as the endpoint there. You could see they use 50%, greater than or equal to 50% worse outcome compared to if you're pacing less than 50% of the time. And then also, by the way, other studies have shown previously in some pacemaker studies that the risk of AFib is higher when you're pacing the ventricle. That's why atrial-based pacing is beneficial, and not a significant difference, but the meta-analysis here has suggested a trend towards a higher chance of having strokes too. So not only do you have heart failure, you can maybe develop more AFib. And this, in MOST, which is a pacemaker study, looked at percentage pacing. If you're pacing 40% of the time or more, survival free from AF was much higher than if you were less than, so the solid bar compared to the other bars. So you did better again if you're pacing, less than 40% of the time. And so there's we're fortunate because all the device manufacturers and engineers have thought about all this and put in lots of ways for us to minimize it. Atrial-based pacing algorithms, adaptive AV delay algorithms, and pacing mode switch algorithms. So we do have the managed ventricular pacing here. The Medtronic MVP mode is very effective to really minimize pacing. And so, once again, our consensus, not just the consensus document from HRS and the multinational it's a not just HRS, but the other arrhythmia societies were involved in that one. But also actually the Brady pacing clinical guidelines say that you need to minimize ventricular pacing and actually specifically say in the Brady practice guidelines that you want to pace, if you're pacing more than 40% of the time, even if your EF is only 36 to 50% based on another study called Block HF, actually, you can actually implant a CRT device, either one with a 5E pacer in the CS, or at that time it was hip bundle pacing. Hip bundle pacing is more out. Now it's more, left bundle area pacing, but this is in the consensus statement. Mentioned just briefly evidence-based programming for CRT, a case here, and these are things we see like pretty frequently in the office. Non-ischemic cardiomyopathy, chronic heart failure, had a left bundle, had a CRT implant, and long-standing persistent AFib. But patient says, I'm not feeling any better. I have the CRT device. And you can see in the office at rest, this looks pretty good. Patient's bi-V pacing, a nice right bundle in V1, QS out and V6 and lead 1. So you have either a left lateral position probably or a posterolateral position. You're in a fib, underlying because the patient has persistent or permanent AFib. And this is how they're programmed in terms of their rate cutoffs. But what we want to point out here is the percent pacing. And, that is certainly, not 100%. It's in the 60s, right? So that's a really low percent bi-V pacing. You put in the bi-V device, you put it in and you want it to pace because you want to improve their heart failure and improve on synchrony. And then you see this, and you got all this information, right? You get this on remotes too. The patient's been developing some atrial fibrillation, and here are the rates in AFib. So the question here is, what is the reason for poor response to CRT? The first possibility is that you have a poor LV lead position at implant. You have a suboptimal frequency of bi-V pacing due to rapid rates in AFib. You have frequent PVCs. I may have been leading you to the answer, but poor response of bi-V pacing in patients who have non-ischemic cardiomyopathy in general. AFib. And so we need to look at these things and manage them. That's why, you could say, yeah, we have device nurses, but we need more than the nurses, right? I mean, we need to have someone supervising them, to say, well, what are we looking at and what do we need to do to care for the patient? So when we were talking to our hospital administrators about resources and we want to say, well, they're not going to take care of everything. Still we need either, a higher level practitioner, APP, or we need a physician to take a look and decide on management. And if you look at just some data, what are some of the reasons for poor response to CRT? Well, many. And this particular, I think this was at the Cleveland Clinic, they looked at their patients and about 32% were due to arrhythmias. You could have more than one reason. Some were, they weren't programmed right, inadequate settings, suboptimal medical therapy, lack of baseline synchrony, a variety of different things. But arrhythmias are very common. So what percentage of bi-V pacing do you need? Does it need to be 70? Does it need to be 80? Well, this is one study that looked at, it's a post hoc analysis of CRT patients in some of the studies there. So looking at heart failure, hospitalization, and mortality. So if you're 0 to 92% pacing, you're the outlier line here. So you did worse compared to if you're more than 92% pacing. So 92 looks like a goal. In this study, looking at survival, this is from a cohort from a remote monitoring system, the Latitude system, 98% is the number you need to be doing to improve mortality outcomes. And so this is incorporated into the consensus document also. So it just says highest achievable and preferably 98% or more. So when I go to the office and see the patient, when I'm reading the remotes, over-reading them, I want to make sure that they're bi-V pacing while I put the device in. I want to make them, better. And there are certain algorithms, to even in AFib, you can get a fusion complex that you can, you can program on in the device to, promote bi-V pacing to some extent. So overall, just in summary, we have, things that we do. It's a comprehensive approach, right, to this patient. And we're a team. We're a multidisciplinary team, right? We have nurses, we have technicians, we have allied professionals, and we have physicians, electrophysiologists that we need to program the device appropriately with appropriate detection rate, appropriate detection duration, put on discriminators, and put on ATP. We want to make sure that we're, minimizing unnecessary RV pacing if it's a single single chamber, dual chamber device. If it's a CRT device, we want to maximize CRT pacing. We want to look at the patient. Are they young and healthy and likely to, get sinus tachycardia? What about their work environment? Are they going to see EMI? How we're going to deal with that in their heart failure therapy. And then other concomitant therapy for their heart failure, drug therapy, might need antiarrhythmic therapy or ablation for arrhythmias, as well as following. And everyone should be followed on remote monitoring that we'll hear more about, and making sure that we have continuous follow-up. So that's basically a very broad overview on, mostly the data with some examples in there. We'll have a lot of time during the workshops to take a look at these electrograms during panel discussion and trying to troubleshoot. But I just wanted to make sure everyone had a baseline knowledge of some of these things that we will be talking about and reviewing some of the electrograms. Thank you. And I'm happy, I think we have like 5 minutes if you have some questions. And feel free, and I do encourage, the cardiology fellows, because I know it's harder, for, somebody to absorb all this stuff as a cardiology fellow and learn everything else about cardiology. So feel free to throw out any questions or comments. Yes, thank you.
Paying attention to the dates of the studies that you presented, mostly in the early 2000s, 2005 to maybe to 2010, but there hasn't been anything recently, especially in terms of ICD programming or CRT optimization. Do you think we've reached a good level? What else is left that needs to be done?
Yeah, no, I think that's a question. And to repeat, I don't have to have a microphone because there are some remote people, but the question, is there something else that we could still do? Do we need to, so what do we need to be? If we're down to 2 or 3% inappropriate therapy, is that good enough? Is that, or are all these other, evidence-based programming good enough? I'd say 0% is where our goal should be, but, we may not obviously get to 0%. So I think, the last study was the Medtronic study when because they have all those other, algorithms like T-wave and noise detection. That was, I think, 2015. That added a little bit, or 2016, I think it was published in. So that probably was since the consensus statement. I think the other newer stuff, and I, reviewed more recently the ATP programming, and I think, that is something a little bit more is can you program on the ATP therapies more aggressively? Can we, some people just, program on 1 or 2 bursts and just say, let me get them shocked and get them out of the rhythm. Is it safe? Is it efficacious? How much of that? So there's a little more data in more recent years. I think especially now that we have, devices like the subcutaneous device that does not have ATP, there's that big controversy. And there is a study, a prospective study, because a lot of these are not randomizing ATP versus no ATP. There may be some room there to decide, is that something that is beneficial? We don't have that, because sometimes, prospective studies, we were programming things, there's bias entered into that, maybe based on what we've seen already on their monitor, on what they're having to program around that. So I think, to answer your question, I think we've done a tremendous job compared to where we were. I mean, the Scud heft, it wasn't like it was, 30 years ago, or, but from there, and even, the primary prevention trials, a lot of those people got inappropriate therapies, and it's really amazing. And I look at this and say, even with made it RIT, did we really underestimate the benefit of ICD therapy in some of these primary prevention trials because we programmed them lower, right? And we, out-of-box settings were lower back then too. So maybe we did underestimate some of the benefit of therapy. So I think, and this is just constantly changing, and so I'm hoping we could still do a little better. We don't have a lot of room to get to 0% now, but, getting down as low as we possibly can. I think also in the other algorithms for maximizing CRT. And a lot of it, though, and I hate to say it, a lot of times people stay at out of box, and the manufacturers are really good at trying to incorporate that in their next, devices to update that based on the evidence. But the other thing too is even programming things like, your rate cutoff high enough so that you're going to be bi-V pacing. Don't put that at like 100 and 110 beats a minute. If people can get sinus tach at 130, and they're not, fully beta blocked. So to allow it to, to atrial synchronous ventricular pace at a faster rate. So I think it's a great question. I don't know. I'm hoping, we'll still see more, more advancements in this area. Yeah, great question. Other thoughts or comments?
Appropriate therapies before, in terms of an outpatient practitioner standpoint, like when you're pre-implant, like do you say there is a risk of inappropriate therapies? As I'm becoming a physician from an outpatient standpoint, I'm just trying to understand how to word this.
I think that is a terrific question. I think that we don't have as many discussions about a lot of things that we probably should when people get implants, including like, end of life kind of things. Many people don't talk about it until they're, on hospice. But I think in terms of, inappropriate therapies, I do say, and sometimes they're in the hospital too, and they come in, and they're in the hospital already. But I do mention, do I focus on it? No, especially now since I know I'm going to pay attention to the programming now that we get inappropriate therapies at a low rate. I will mention that there's some chance, there could be, therapies for rhythms that you are not life-threatening and stuff. So I don't harp on it, but I don't want to scare them off too much. But because overall, we know the benefit of ICDs and pacemakers, obviously too. Not going to get inappropriate therapy for that, but I do tell them too if they have an occupation, and this comes up a lot. Is they have an occupation, they're an arc welder, or there's certain things that they do, and there's also new equipment. I think now the big thing is these spinal stimulators. I feel like everyone is being recommended a spinal stimulator. It's and there's recommendations, and Medtronic actually recently just sent me their latest because they're putting these devices in all the time, and I had a pacemaker. I mean, this patient was pacer dependent, and also had an ICD, so can get shocked inappropriately, and so I think there's some areas of limited gaps in evidence too. Is there are large randomized trials looking at that? No. Will there be? Probably not. But I think we can get a better body of evidence looking at inappropriate therapies for things that patients, that they do on their own or secondary, but just to let them know, that there are things in the environment. If they go to the OR and there's electric cautery, they have to obviously know that you have a device and there may be some programming or a magnet may be placed over the device. Yeah, good question. Yeah, so we need to do more of that.
In patients with like a history of recurrent atrial arrhythmias, like if they have AFib, do you consider putting an A-lead to help discriminate and decrease inappropriate shock? I know that's always a dilemma. There's no mortality benefit to it, but would you?
Yeah, that's an excellent question. So that is one of those areas I have to say that because even, on the appropriate, so we have another appropriate use document that should be coming out in next year. But even on the discussions, there's like two sides that some people always put dual chamber in, and some people, almost always stick to a single chamber based on, made it and all the other primary, said have a single chamber device, and the evidence was obtained with single chamber devices. I actually don't put them in routinely. If I think they need atrial pacing or they might need atrial pacing, I do. One of my partners does it 100% of the time, puts in dual chambers. I do like to see the atrial electrograms. Now Medtronic does have that, you could actually see if they're having AFib, because it's nice to know if they're having subclinical AFib. That's the other reason, because you want to, that's a whole other discussion on subclinical AFib and when to treat subclinical AFib with anticoagulation, in particular. So I like to see the subclinical AFib. So I feel okay with it, with having that, so I could still see it on the single chamber devices. But there's the randomized trials, and there was one that Paul Friedman was involved in. I forgot the name of that study, but randomized. It didn't show any benefit overall and I think there was even a higher risk of lead dislodgement. Atrial leads can dislodge. So that's really one of those areas that we don't have a very large multi-center randomized trial to look at single versus dual. And I think that is one thing that's very operator dependent. I don't know. I'm curious what other people do. Do people here implant dual chamber devices most of the time, or?
I may never get invited to Medtronic again, but Biotronic has a DX lead that has atrial sensing capability, and it's a single lead ICD. So that's my preference if I'm convinced someone doesn't need pacing and just needs defibrillator, and they have atrial arrhythmias that I'm trying to monitor.
Yeah, so I don't know if people know, that's a great point, because so if you don't, you can't adequately pace through this electrode that's floating in the atrium, but it does sense, and you could also look at stored electrograms. I assume they store all the electrograms for that too. Yeah, good point.
So, is this on? Yeah, okay. So Andrea, I think you covered it really well, but I think the things you think about are, one, are you going to need to start the patient on an antiarrhythmic drug to, you're going to end up atrially pacing, right? Because, before you commit to implanting your defibrillator, ideally you'll have the patient on your optimal base. I mean, you want the patient, one of the reasons we like putting in primary prevention patients optimized guideline-directed medical therapy is that if you start on, 3.25 milligrams of carvedilol twice a day and implant your device, and then you titrate up to 25 twice a day, and then the sinus rate's 40, that's a different situation than if the sinus rate's 70 and you're already on maximal medical therapy. So you want to make sure you don't have an indication for atrial. That's the first and most important thing. Then the next question is, what about atrial arrhythmia burden and monitoring? And there are single lead methods that different manufacturers have, including Biotronic, but other companies too, for assessing AF burden. They're never quite as good as none of them are quite at the level of an atrial lead, but on the other hand, it's, you don't have the morbidity and power consumption of that atrial lead. And then the third issue is, if you have a tachycardia, SVT-VT discrimination, right? Well, there are plenty of patients with AF who have poor AV conduction, right? Or weak AV conduction on beta blockers, right? And they're the patients who are not at much risk for rapidly for who you don't think have any likely need to, be programming an SVT-VT overlap zone, right? So those patients, right, it's less important to have your hands around an atrial, to have an atrial lead. Finally, even if you have an atrial lead, should you not use it? Or if you try to put it in, you should forget about it. And that is if atrial sensing is unreliable. Because the only thing less bad, for SVT-VT discrimination, I can see Paul nodding his head, right? That than no atrial lead is an atrial lead that doesn't sense adequately, either oversensing or undersensing, right? So if you put an atrial lead in, it's your responsibility to make sure that sinus rhythm P wave is big and there's no far field R wave, because unless you put it in an AF and induce AF, because when you induce AF, the signal amplitudes and the filtered signal amplitudes will be way down. So I think the reason that randomized studies don't show benefit is probably there's some patients who actually do benefit. And there are probably a lot of patients who don't actually benefit, and you want to think through at a little more nuanced level than, atrial fibrillation is in the chart, I should put an atrial lead in. And I think that's sort of how I would think.
Yeah, great comments. I didn't actually comment on the atrial sensing for the algorithm too, so you could double count that far field. So what I do put, if they're bradycardic, because it's easy enough to do when you're in there, but not indiscriminately. If I think they're going to need atrial pacing, there's a good chance, I'll put it in. But you could oversense and then double count that, and your algorithm won't be as reliable. So not just the low amplitude, P wave. So I always want to see that electrogram after I put it in. Oh, great. I think we're done or even over now with the questions, so thank you. And next, I think I don't have my agenda in front of me.
I can introduce you. Hi, it's Tina Baikaner. I'm a faculty at Stanford. I work with Dr. Paul Wong, and this is Christy McIntyre. She's at Mayo Clinic. We're going to present pacemaker diagnostic case-based approach. So Dr. Russo went over the big picture trials that led to the programming changes. Now this is the more detail on what exactly is happening in this strip, in this recording. And Christy will do most of the talking, and I'll jump in.
And we didn't intentionally dress the same today, contrary to the way it might look. I should talk to her before tomorrow. So welcome. We've tried to include something in here for everybody. So if you're a cardiology fellow, if you're an EP fellow, hopefully you'll take something out of this, and there is a participation aspect, so brace yourselves. All right, so our objectives for today, we're going to go through some of the different types of pacemakers, including some novel technologies. A lot of this will be review. We'll look at the NVG pacing code. We'll talk about some of the fundamentals of pacemaker function, and then hopefully we'll work on recognizing abnormal conditions and the potential causes through some cases. And we have 30 minutes for this challenge. So this is my approach when I approach a patient with a pacemaker, and the majority of this talk is pacemaker-based. So I like to break it down into the device, the leads, and the patient. And the patient component includes the events. So very briefly, and there's many different types of pacemakers. It's not as simple as it used to be. So we have single-chamber pacemakers, and there can be single-chamber atrial pacemakers as well as single-chamber ventricular pacemakers, which is the most common. You might see that in something like chronic atrial fibrillation. But as far as the atrial pacemaker is concerned, there's cases where there might be isolated sinus node dysfunction where you may choose not to put in a ventricular lead. Dual chamber pacemakers, we see them quite commonly. We had an interesting debate a few minutes ago about the use of atrial leads in some scenarios. So that's when we have one lead in the atrium and one lead in the ventricle, and that provides AV synchrony. And this is just a representation on a PA and a lateral film of where you expect to find the leads. So we're putting them in the right atrium and the right ventricle. So we expect them to be right-sided structures, and the right ventricle is an anterior structure. So when you look at the lateral view, you expect your atrial lead to hook forward into the right atrial appendage, and you expect your right ventricular lead to be anterior as well. You do not want to see it posteriorly. Otherwise, you may have a problem. And then we also have more complicated devices. So this is an example of a defibrillator. And what's special about this one? Well, it's the presence of the left ventricular lead. So we see that posteriorly. So you see the nice geographic separation of the right ventricular lead and the left ventricular lead there, really nicely displayed on the lateral view. And we can tell this is a defibrillator for the cardiology fellows in the audience because we have that shocking coil on the right ventricular ICD lead, and the generator is also quite a bit bigger. And this is a CRT device, so they have a tendency to have a higher volume as well. And there's some newer technologies out there as well. So we used to be fairly kind of stuck with leads and pockets and incisions, and now there's leadless technology as well. So there's single-chambered leadless technology as well as dual-chamber leadless technology, which is a really interesting development in the pacing world. So what about the leads? So when we think about leads, it's important to understand the concepts of sensing, pacing thresholds, and impedance, and the sorts of things that can go wrong that we can identify. Because that's a lot of what you spend your time troubleshooting in the device clinic or issues in those domains. So in terms of some background, sensing is the ability of the pacemaker to see when intrinsic depolarization is occurring. So the electrode senses the intrinsic electrogram, and if it senses it, it can inhibit pacing. So pacemakers sense depolarization by measuring changes in the electrical potential of myocardial cells between the anode and the cathode. So in an atrium, if we're looking for an acceptable P wave, we're typically looking for it to be big, but above 1 millivolt would be acceptable. In the ventricle, above 5 millivolts, but obviously if it's 10 or 15 or 20, you're pretty happy as well. Well, what about sensitivity? A lot of people don't like thinking about sensitivity because it's a little backwards and it can be a little bit confusing. So that's the level an electrogram has to exceed in order to be sensed by the pacemaker. And we program the sensitivity after we measure the size of the intracardiac electrogram. And we usually set it at half the P wave or half the R wave. Now, If a device has a high sensitivity number, that means that it's less sensitive. And sometimes you can set your sensitivity too high, so it can't see anything. The fence is too high. Now, you can also make a device more sensitive, which is a lower sensitivity number. You make it too low, then it might see too much. So it's important to set it right. So we want to have adequate sensitivity for a device, because once the signal exceeds the program sensitivity, it will be sensed by the device. So it's all about that fence, so that you have the level of the fence appropriate to the situation. And our needs in a pacemaker are different than our needs in a defibrillator. In a defibrillator, we want to see ventricular fibrillation, which can be quite small. In a pacemaker, we want it to be able to see P waves and R waves. Well, what about problems with sensing? So if we have an over-sensing problem, that can lead to under-pacing. If we have an under-sensing problem, that can lead to over-pacing, and that can lead to calls in the middle of the night when you're on call. So if you're the cardiology fellow or the EP fellow, things on telemetry, changes on electrocardiograms can generate consults, can generate phone calls for you. So it's important to understand them so that you can then move forward to troubleshooting. Well, what about threshold? So a threshold is the minimum stimulus amplitude at any given pulse width required to consistently cause myocardial depolarization. So we tend to decrement the amplitude, and we look for when we lose capture. And then our threshold is when we were last consistently capturing the myocardium. So you have to be watching what you're doing while you do that test. It's a little scarier when the person's pacemaker dependent. You want to watch really well because you don't want to make them black out. What about impedance? So that's the sum of forces opposing flow of current in an electrical circuit. So it's components of the lead, the tissue, and the electrode tissue interface. And then we have ranges. So we consider a low impedance to be around less than 250 ohms, and that might suggest that there's an insulation defect. We get worried about things like lead fracture if it's above 2,000 ohms, for example. But one of the key things to remember is that we're looking at changes over time, and we become concerned if there's an abrupt change. So it's important to have a sense of what the trend has been for our impedance values, because we don't like sudden changes. And things like remote monitoring, which we'll talk about tomorrow, can be very helpful when looking for those warnings, those lead integrity alerts. And that's an example of a lead no longer in the body that had a breach in the insulation. So things you don't want to see that you might appreciate fluoroscopically, but it's nice when they're not in your hands after an explant. All right, we breezed through that. You've got it, I hope. So here's an example of something that you might get called about in the middle of the night. So what do you observe here? Say it loud. Undersensing. Okay, very good. Perfect. So what we see is that the intrinsic beats aren't being sensed consistently. So our scheduled pacing is delivered as though nothing ever happened. Very good. It doesn't stay this easy, I hope. And what about here? What do we have here? What's the observation? Even if you don't know the answer, just describe what you see. Okay, so we have some comments for failure to capture, perhaps, I'm hearing. Any other observations? So if you look along the marker channel, what do you observe? Yeah, there's too many V's, right, for what's happening. So if we look at the marker channel, we see the device thinks there's a whole lot of intrinsic activity happening. But when you look at the ECG, there's no intrinsic activity actually present. So this would be an example of oversensing leading to underpacing. What about this? A little something different. Yeah, so the device is firing, but nothing's happening. So we have failure to capture. We don't like seeing failure to capture when you've done an implant. So this is an example of a patient who had a pacemaker who represents with failure to capture 4 weeks after their initial implant procedure. This is what they looked like on postoperative day number 1 with their x-ray. Any thoughts there? So the pacemaker on that day was working great. Beautiful R wave, beautiful P wave, phenomenal thresholds. Discharged home. Anything exciting on that x-ray? Are you happy? You're allowed to be happy. Okay, nobody seems dramatically unhappy. So what are you gonna do next? So you've interrogated the pacemaker, you've confirmed there's failure to capture. I love chest x-rays. Okay, this is real life, and this is what you get sometimes. It's a little fuzzy. Any observations? Yeah, I'm hearing a lot of mumbling, but I think somebody might have said RV perforation. This is my attempt at a cartoon. So we have, oh, well, that's not subtle. So your lead should never be outside the heart border. It should never be in the chest wall. And this person probably had some chest wall stimulation. So they basically gave themselves a pericardial window. Good news is there's no tamponade. So what are you going to do? Well, it wasn't outside it yet. If it had a generous, I don't know what the others in the audience who do this a lot would say, if there was a generous amount of slack, you could envision that if you were at the apex or you weren't butting the septum, that bad things could happen. There was enough redundancy there. And clearly there was sufficient lead to reach the chest wall. So this was a scenario where the failure to capture was because the lead was no longer within the heart. And it was touching the chest wall, and there was a little bit of chest wall stimulation in this case. So you never want hiccups or chest wall stimulation after a pacemaker. It's good to take a history, yeah. It's a great question, and if it was my case, I would tell you, but I don't know. It would be different. Yeah, so you're looking at everything. So you would expect that your sensing would be not good, and you'd expect not to be capturing myocardium, and then you look for what you are capturing. See what the patient tells you. Put your hand on the chest when you do the capture. And I do that routinely when I don't know about you, but I routinely feel the chest, feel around the abdomen when I implant a lead and pace at maximum output to make sure that nothing else captures. So failure to capture can happen for a lot of different reasons. Sometimes it's our fault, sometimes it's not. So there can be generator failure. Maybe you've put the lead in the header poorly. Maybe you've just programmed it wrong. If you program it subthreshold, it's not going to capture either, or you don't give a safety margin with your programmed output. Lead dislodgement can certainly lead to failure to capture, as could lead fracture. And sometimes there's patient factors, so maybe they've developed fibrosis at the lead tip. Maybe they just randomly developed granuloma from their sarcoid where you implanted the lead. I've seen that once or twice, not good. Or there can be temporary things like ischemia, infarction, hyperkalemia, antiarrhythmic drug therapy that contributes to this. But it's always good to check the programming. And one of the benefits, one of the reasons we do a chest x-ray is not just to look for pneumothorax after an implant, it's so that we have a frame of reference to compare it to if they come back with changes in their status down the road. Well, what about this? What's the observation? So sometimes you'll just breeze right past this when it gets printed out by the programmer. This is a heart rate histogram. Okay, so it's looking kind of flat. I'll give you that. What's the other observation? What's up with that? Should we have a bar over there? So this is the atrium, I'll give you that much. So what does this mean? So do those high atrial rates mean that the person has atrial fibrillation? Should we get out our prescription pad and order some Eliquis or Xarelto or some warfarin? Got to look at the EGMs, exactly. So here's some EGMs. What do you think? Are these high atrial rate episodes? Should we be enrolling the patient in Artesia? Yeah, it looks not really physiologic, does it? I'm hearing the word noise for those of you in our virtual world. And if you look at the electrograms, they're very sharp. That's not what AFib is supposed to look like. So what can noise mean? Okay, so some people are wondering maybe there's some muscle factors. Are there any lead factors that could contribute to the presence of noise on a lead? Say it loud. Fracture, yeah. What would be another tip-off that there might be a fracture? Well, look at that. Look at the variability in the impedance. So if we look at the impedance, it's anywhere from about 650 to 2,810 ohms. So what are some things that you can do in the clinic? Yeah, so you can do dynamic maneuvers and you can do impedance checks and that sort of thing, looking at the electrograms while you do that. So it's always fun. You get them to push their hands as hard against each other as they can. Sometimes they're really strong and they push you away and you slide across the floor, cross their arms across the chest. I'm not joking, I have slid across. Some people are really strong, some people are not. So, but you want to do those maneuvers, you want to watch the electrograms, and you can actually check your impedance while you're doing the maneuvers as well, because if it's dynamic, you want to be able to catch it. And then you figure out what you're going to do about it, if you're going to revise the lead or leave it alone. And you do a chest x-ray. And how often do you see something on the chest x-ray? Almost never. It's rare. In this particular case, there was a little defect that was apparent, but most of the time I find the chest x-ray it's insufficient to say that you don't have a fracture, and that's important to remember. So do the x-ray. You might see something, you might get an answer, but don't feel falsely reassured if the electrograms, the impedance, the threshold, the sensing supports a fracture. So this was a patient who came to the emergency department because they felt weak and dizzy. And they thought that got better when they got their pacemaker put in, and their pacemaker's programmed at VVIR 50, but here they are pacing at 34 beats a minute. Why? So I heard 1 vote for pacemaker syndrome and 1 vote for T-wave oversensing. So how would you figure out if this was potentially T-wave oversensing? Intracardiacs could help, but sometimes calipers help too. So where is it starting the clock? So in this case, it was that T-wave, and that's exactly what was happening. So with some reprogramming, they were able to feel much better and not need their lead revised. Here's a different case.
All right, last 2 cases I think that we have. This is a 77-year-old gentleman, came to Stanford. He has a history of AFAT and bradycardia, so had a dual-chamber Medtronic pacemaker for tachybrady syndrome at an outside hospital. So we don't have the original images, but he came to our emergency room with palpitations, and that's our first interrogation. The first one is a surface tracing that you would appreciate, and the second line is the atrial tip to rig, and the third line is ventricular tip to rig. Let me see a show of votes. Who thinks this is sinus with a very prolonged PR? So the first A signal is going to the next RV. No one. Who thinks this is an atrial tachycardia? No one. Who thinks this might be a slow junctional rhythm? Good amount of votes. Who is suspicious that there's something else going on? Dr. Swerdlow, right? Let's go to the next slide. All right, so what next? We check the device, right? The tracing on the left, and I tried to highlight it. Let me not say it wrong. I believe let's just look at the left. It's atrial threshold testing. And you see that it loses capture on the second line, that there's an AP and a no associated pace signal at the bottom. I don't know if you have a pointer that Chrissy can point to. Oh, there you go, yeah. And where it loses capture is right there. So it has a pretty decent threshold. The atrial lead is working fine, right? Its pacing threshold is around 1 or 1.5. I can't read from here. Look at the RV pacing on the right. You can see the intrinsic RV EGM, and you can see what the pace one looks like as the second circled one, and then the threshold, and the RV threshold is perfectly fine too. What next? Chest X-ray.
What are you looking for on your chest x-ray? To where?
All right. A little fuzzy, but exactly what you suspected. You see the generator, you see the RA lead. Let it not fool you. It still is curving upwards, so it still looks like it's, potentially maybe in the atrium, but not quite.
It actually looks about the right spot where you would put a his bundle pacing lead, how that would look on the X-ray. But yeah, the RA lead is this large on this one. So you're still in the ER, you're the cardiology fellow on call, and you saw that X-ray, you saw those thresholds. So the atrial pacing is actually pacing the ventricle, and the ventricular lead is actually still pacing the ventricle. So you can imagine some badness can happen with double stimulation. Immediately, what programming change you would do? AAI? VVI? Most people, okay. VDD? What the heck is that right now? You wouldn't do that. So definitely reprogram it, get rid of the atrial lead out of the picture, even though it seems to be pacing fine. You don't want to rely on the potentially dislodged lead there. And would you do a lead revision? Yes, right, okay. All right, here's the X-ray. So that's, again, it's curving upwards, but now that's where the RA lead is supposed to be more on the left side, as you see on the revised picture here. All right, here's another example, 93-year-old presenting with weakness. You see a 12-lead ECG, and I think you have more clinical background on this one. There you go.
So she's a frail 93-year-old who's been feeling lousy for a couple of weeks. Why is she feeling lousy? Yell it out. It's not a trick. Yeah, she's in complete heart block, exactly. So what are you gonna do about it? Her electrolytes are normal, her renal function's normal, her echo is normal. Pacemaker, and what are you gonna put in her? 1 vote for Micra. Some votes for dual chamber. Anybody want to put in a single chamber? Nobody? I'm from Canada. We do that a lot. So she gets a dual chamber pacemaker. Her atrial lead needed to be moved around a couple of times. She doesn't have great sensing in the atrium, but eventually a great spot was selected. This was her X-ray the next day. And her device interrogation the next day was pristine. Beautiful P wave, beautiful R wave, lovely thresholds. She gets up, she puts on her makeup, she's eating breakfast. They do her ECG before discharge. What's happening? Is it normal? Is she going home? What's the observation? Okay, so I'm hearing whispers of concerns about atrial undersensing. So when your atrial lead tries to capture something, what does it capture? Sometimes nothing. Weird, right? Her X-ray looked good, her interrogation was fine not that long ago. How's the V lead working? Pretty good. What are you gonna do? Or just another chest X-ray. When in doubt, do another one. Darn. I don't know what she had for breakfast, but it was vigorous. So now what do you do? So we've got this frail 93-year-old. She probably weighs about 92 pounds, soaking wet. You gonna leave it? Are you gonna put it back in the atrium? Are you gonna take it out? Okay. So ultimately the decision was made that they took out the atrial lead, they pinned the atrial port because she was feeling great with single chamber pacing. She got reprogrammed to VVI for the rest of the weekend, and that's what the operator opted to do. So the question is, do I worry about interaction? I would in the long term, so I wouldn't leave it there. So it did come out. It's in a trash bin somewhere. But I would worry about it just kind of floating in the ventricle, causing PVCs, potentially being arrhythmogenic. So I think taking out the lead was definitely the right call. And back to our atrial lead discussion before, atrial leads are great when you need them, but every time we add an extra lead into the system, there is a higher rate of complication. So you want to be mindful and consider your risks and your benefits. So I don't think a lead revision would have been inappropriate, but the operator opted to take it out, and I don't think that was inappropriate either, given that she was doing well.
I think it potentially already was causing some ectopy.
If you look back at the
12 lead, there were PVCs exactly similar
Yeah.
looking to the pace speeds. The middle white beads right in the middle of the tracing.
Yeah,
You can assume they're coming from where the other actual pacing lead is, right, causing that ectopy. It's already causing trouble.
the morphology is slightly different than the paced morphology, and it's not where you would expect her to have her next programmed beat. But it's real life. It happens. Lead dislodgements do happen about 1 to 2% of the time, so you need to be prepared to deal with that. I like this case. 65-year-old woman. She has possible symptomatic bradycardia. She gets a dual chamber pacemaker, and then she has a stroke 6 months later. This was her implant chest x-ray. What do we think? Everybody's screaming left ventricles. Everybody on the same page with why that is. So we looked at that x-ray before when we talked about the fact that your atrial lead should point forwards because that's where the right atrial appendage is. And where's the right ventricle? Anterior. Where's the right ventricular lead? Not anterior. And it seems to cross over kind of high. So, okay. This was her post-implant electrocardiogram. So if you weren't sure, what does this tell you? So what's her paced QRS morphology look like? Right bundle. If we put in a CRT, we'd be pretty proud of ourselves. Instead, this is like LV endocardial pacing without anticoagulation. So when you do that post-implant chest x-ray, when you do your post-implant electrocardiogram, look at it. And one of the challenges that we have with post-implant electrocardiograms is if they're not pacemaker dependent and they're not actually ventricular pacing, you might not actually see this, but in this case, this was seen and not recognized. So ultimately, she did get systemic anticoagulation, neurology was involved, she had a transesophageal echo, and the lead was moved to the right side of the heart, and she fortunately did very well. But it's really important to remember that it's not just the threshold, it's not just your R wave, it's also what your chest x-ray, your lateral film, and your electrocardiogram look like. Yeah. No, they crossed an atrial septal defect. So if you look back, one of the clues is you really shouldn't cross into your right ventricle above where your atrial lead is. Like that's a pretty high crossover location. And then our other clue is that it's a posterior structure. So assuming that a person's, right ventricle goes to their lungs and their left ventricle goes to their body and that they don't have dextrocardia or anything like that, your x-ray should never look like this. The other scenario where you might get fooled is if the right ventricular lead ends up in the coronary sinus, but you wouldn't expect a high takeoff like that in that case, and you wouldn't expect a stroke. Mm-hmm.
On the X-ray.
Mm-hmm.
It should ideally be below the clavicle when the lead is coming out from the device and crossing over right above that, which I don't think we can clearly make out here. But if it's arterial, it would be higher.
Right.
On the medial
yeah.
aspect of the clavicle.
Yeah, we're quite happy that the atrial lead is on the right side of the heart, right? So
Right.
we see that in both planes, the two leads are traveling together in the axillary venous system. So we're happy that we're venous at that stage. If you look on the internet, you will see beautiful dual chamber pacemakers in the left main. So you do want to make sure. So when I get access, when I get vascular access, I pass my wires down to the IVC and I make sure it's below the level of the diaphragm. Because I want to quadruple check that I'm in a venous structure. And at Mayo, we use micropuncture a lot, and you don't get that nice pulsatile feedback on a micropuncture. It's one of the things I dislike a lot about micropuncture, because I like, all of the clues that I can have, and I find that's more subtle. So I always make sure that I pass wires down to the IVC. Because you really need to become comfortable with your fluoroscopic anatomy and having ways of double, triple, quadruple checking what you're doing to make sure that you're doing it right, to make sure you're in the right location. Because devices aren't benign. It's never just a pacemaker. It's never just a gen change. We can do harm with these procedures, so we want to make sure that we're doing everything that we can to do it right. And this is a little something different. So most of this was a pacemaker talk, but this was a routine clinic visit for a patient with a defibrillator. What do you observe? So do we have a single or a dual chamber device? Yell dual. Dual. Cool. How does the atrial channel look? Fantastic, right? Nice and clean. A's are where the A's are supposed to be. What about the ventricular channel? We don't like the look of that, do we? And what do we think of the marker channel? It's being sensed, right? So what do you think the patient was being asked to do at that point in time? Exactly. So he was being asked to do dynamic maneuvers on the basis of an impedance change. And this is what was observed. So what do you do now? So let's say that this is a secondary prevention device put in for ventricular fibrillation. This particular one, so we're going back 6 years. I believe he was pushing me away. This is one of the guys that was sliding me across the floor. And I got somebody else to do a screens, like a print. It was an intensely dynamic maneuver. Yeah, so, you know, you're going to turn off ICD therapies, and if it's a high-risk patient, you're going to be admitting them into a monitored setting until you revise the lead, and then you're going to make a decision about whether you extract an implant or cap and abandon and put in a new lead, which is a conversation for another day. But it's important to do those checks and make those assessments. I would not. Well, I think the concern is with defibrillators, the sensitivity problem. So the ICDs have dynamic sensing because, you know, you want them to be able to see the ventricular fibrillation. So we need to kind of balance our pacing functions against our defibrillation functions. So the problem is if you get changing your sensitivity, you don't want to miss ventricular fibrillation. So, you know, you could make the argument that in a lower risk primary prevention, never had therapies patient, you might not have to admit them depending on where you live, like in Canada versus the United States. So we have done that in patients who are in my Canadian practice. If we had patients from far away who needed to travel, get the device therapies turned off and then admit them up to our hospital like the next day. But in high-risk patients who are secondary prevention or higher risk substrate, you know, especially if they've had recent therapies, you'd be admitting them to hospital. And it is an important question because I don't know about your hospitals, but I know I get emails every day about whatever stoplight color we're on in terms of whether we can or can't admit patients easily to the hospital. So, you know, bed pressures are a real thing, but you have to consider the risk, the arrhythmic risk of the patient and what the potential harm is with your intervention. And
If I'm doing that, I would do a DFT test for the least, you know, to make sure that in your new sensitivity setting, you're still putting the patient into VF and proving that it's a sensing adjustment. Maybe not, definitely not this case, because I can see even the intrinsic R waves, but you gave a different hypothetical example, and that might be a different situation.
Yeah. There is no, the LV lead was actually fine in this scenario. This was, the RV lead was the problem. Yeah, no, I see what you're talking about. I'm trying to remember the exact scenario. What I can tell, this was from my fellowship, which was not yesterday, so I apologize that I forget
Probably
some of the details. Yeah.
Or coilocan.
Yeah. This is true. Mm-hmm. Yeah.
The sensing electrogram is between the RV tip and the shock coil, right? The RV shock coil, because this is probably a Boston integrated bipolar lead, right?
Yeah.
So the fractured conductor you'd expect here is the RV shock coil, correct? And in fact, one of the hallmarks of RV shock coil fractures is that sometimes you see these abnormal signals that are huge on your sensing electrograms when you have a conductor fracture. That's typical of the of the helical conductor to the tip electrode when those guys fracture, but when the shock cables, when the cable fractures and the cable has 49 little filars, right? That you are more likely to see these lower amplitude signals.
I guess if it's coil fracture, that's the one time you wouldn't want to.
Right. So your shock coil is gone on this patient, right? So yeah.
We used to do defibrillation threshold testing. We used to actually test at less sensitive settings. We might test at like 1.3 millivolts so that you could, and then you program it at 0.3. So you have that room and you knew it's sensed, but not to arbitrarily, or to program it without doing some testing. Chances are it may still detect, VF, but that is one case that I think maybe still do testing if you're going to do that for some reason.
And I think because we do so little defibrillation testing now, it's not something that people are usually comfortable with coming out of fellowship training programs because, since simple, it's just, unless you're doing a subcutaneous ICD implant or the odd right-sided or some special scenario, it's kind of a unique event that you don't encounter very often.
They have a separate pacemaker.
Exactly. There's something weird about that case. So it's a good thing to think about in terms of the scenarios when you would do it. So I think we're over time. Really good participation. Sorry to those of you in the virtual world that you're not here with us to participate, but we're really enjoying this meeting, and thank you to Medtronic for putting it on. So it's good to have an approach when you approach these scenarios so that you kind of have an algorithm that you go through and not miss things. So consider your device, consider your leads, consider the patient, and then you'll do well. So thank you very much for your attention, and we look forward to spending the weekend with you.
That was great. Good, nice job. And so we do have this interesting, I'm actually very interested for the next session is a 3D cardiac anatomy workshop that we have. Dr. Shivkumar wasn't able to make it, but we have Dr. Mori, I think, right? Here somewhere. Oh, there he is. Okay, he's in the back, is going to lead that. And Dr. Wagner and Dr. McIntyre are going to also work on this also. So.
After about 20 minutes of the lecture, we'll break up into 2 groups. So we'll have one group over there and the other group over here, and then we'll have 2 different hands-on workshops. So after 20 minutes, you'll get your heads up. We'll move into 2 groups, and after 30 minutes, we'll switch and you'll do the other side. So I'll keep reminding you. Thanks.
So good afternoon, everyone. At first, I would like to say my great thank you for Dr. Wang and Dr. Russo for inviting me, and Dr. Tina and Dr. Kirsty for helping me for following hands-on session, and Ms. Sarah and Ms. Ashita and great Medtronic teams to make this happen. So as this is my first time to join this great hands-on session, I would like to briefly introduce myself. I am a Japanese cardiologist struggling to speak English and just crazy for anatomy. That's it. So my question is, the left side is volume rendered images and the right side are MPR images. So which is the 3-dimensional image? The left side or right side? But anyway, this left side image is so beautiful, showing the left ventricular orifice reconstructed by myself. And it is going to show the aortic valve and mitral valve complex here. It's so beautiful. Yeah, I'm mesmerized. The answer is both are 2D because these are projected on the 2D monitors, right? So that this concept is go 3-dimensional. I mean, it is real three-dimensional, and I would like you to share the fun of three-dimensional anatomy to obtain the depth perception, real depth perception. That is very important because our clinical imaging is always 2D because on the 2D monitors, right? So to achieve that, we are doing some time-consuming and painful approaches. Here, I'm showing the perfusion fixation method. The extracted heart is inflated using the flow pump during the fixation to maintain its physical shape. So after the perfusion fixation, you can see here, even this very thin and flaccid right atrial appendage is trying to maintain its physiological shape. This is very important because when seeing the heart right after the removal, it is very flaccid and collapsing. That is not useful for clinical, that is not clinically relevant. So using this data set and replicating this kind of professional photo studio in my lab, we are preparing many digital and virtual data sets to share with all of you. So I hope those data sets will help your daily clinical practice because I cannot bring the real heart here. So now we have more than 5,000 real dissection images archived. Look at this. It's so beautiful, right? Inferior medial papillary muscle, and here is the head of the superlateral papillary muscles. And also we have more than 10K virtual dissection images archived. This kind of virtual dissection using the special software is my specialties. And this is, we have more than 400 anaglyphic archives. So this is a really conventional images, but, and it looks weird, but I would like you to pick up your glasses and just see like this way. Oh my goodness. Look at this one, right? The right side looks more beautiful because one of the light in the ceiling is broken. Yeah, this is so beautiful. Because I have been published more than 20 papers just focusing on this part of the heart. This is my favorite structure. It requires some time for some person to get used to these images. But if you can see this like a popping out from the screen, you can say, wow, see? And the advantage of this kind of conventional technique is like that the so-called commissure, or the apex of the interleaflet triangle is actually reaching at the level of the sinotubular junction. And you can immediately understand or intuitively understand that the central point of coaptation is located far lower than the plane of the sinotubular junction. This is really beautiful. Yeah, because I saw this image more hundreds times, but every time I see this, I'm so mesmerized. And I'm now almost changing my mind to stop my lecture here and just see this image after the rest of my whole talk. But there should be a virtual attendance, and I might be kicked out, so let me proceed this. So this is you can take off the anaglyphic lenses. we have more than 100 GIF images. And the importance is, of course, this is a 2D, but adding the motion to the 2D image makes it a little easy to understand how three-dimensionally located each structure is located. This is the image created to understand the subxiphoid approach for the epicardial ablation. You can see here the left sternocostal triangle, which is located above the diaphragm. It means you are not penetrating to the peritoneal space. This is also called the Lowry's space. Here's Lowry's space. It is not abdominal space. And we have some images that can be visualized on the holographic monitors. This is not the heart stored in the translucent glass box. All of this image is a digital. It's amazing. And now, today we bring some part of our 3D printing collections because these are created from the perfused fixed heart. The quality is very good. You can see here leaflets and tendons, right? And oval fossa, eustachian ridge, coronary sinus. Those kind of detailed 3D printing is now available. And those 3D data set is now used in UCLA as the graduation gift for EP fellows. This is a laser engraving. Very fantastic. So let me revisit the anatomy of the right ventricle before moving on to the hands-on session. So this is the AP view of the heart. And cut the free wall of the right atrium and the right ventricle together and seeing the inside of the right heart, like this way. So here, you can see the septal tricuspid leaflet, anterior superior tricuspid leaflet. Usually this is called just anterior leaflet. And this is the inferior tricuspid leaflet. Usually this is called as the posterior tricuspid leaflet, but its attitude is incorrect because you can immediately understand the septal tricuspid leaflet is located most posterior because you are viewing from the anterior side. So it's the anterior and superior and inferior and septal. Also, especially for EP fellows, it is very important to understand the anatomy of the papillary muscles and trabeculations. Here you can see the anterior papillary muscles and the moderator band connecting to the base of the anterior papillary muscles. And this is a septomarginal trabeculations given the rise of the moderator band. And this is a septoparietal trabeculation that arising from the base of the septomarginal trabeculations. And also at the base of the septomarginal trabeculations, you can see the medial papillary muscles. Also, this is called the septal papillary muscles, or muscle of Lancici, or muscle of Luschka, or papillary muscle of Conus. So it has 5 names. So I'm really afraid these specific terms is not always familiar to any of your young fellows. But it is really important to understand the anatomy and name terms, because if you do not know the terms, you cannot detect it during your clinical practice. This is important because these structures can be localized during any kind of echocardiography, including TTE, TEE, and ICE. My favorite structure is this medial papillary muscle. It's very tiny and cute, right? And even for, like me, as a crazy anatomy guy, it is sometimes tough to recall these kind of names. So I'm training every time, taking the chance. So in this Wednesday, when I was supposed to book my airplane, I called the agent. So, and I said like Shunpei Mori, SM, S for septomarginal trabeculation, M for moderator band, right? That is the appropriate way to be the crazy of anatomy. So again, the progressive dissection focusing on the septal tricuspid leaflet, the part of the anterior superior tricuspid leaflet, and inferior tricuspid leaflet. So the reason this kind of anatomy is important is that these are related to the conduction system. So that is the reason you need to understand anteropapillary muscle, moderator band, septomarginal trabeculation, and tiny acute medial papillary muscles. And if you carefully see this image, here you can see some whitish strand or string-like things, which is the right bundle branch. You cannot always see this during the gross dissection, but in some cases, it is running quite endocardial side, and you can see it, which was surrounded by thin fibrous sheath. That is the reason this is important. And you can find a quite huge variation in the appearance of this septomarginal trabeculation. In some cases, this is quite prominent like this, and the running course of the moderator band. So now we are focusing on the membrane septum. This is my favorite structure in addition to the aortic root and medial papillary muscle. Here, if you add the transillumination, you can see the beautiful membrane septum. It is so beautiful. I think I can stop here and just see this anatomy. Because the opposite side of this membrane septum is left ventricular outflow tract, right? And the septal tricuspid leaflet is dividing the membrane septum in two portions. So here is the atrioventricular portion between the right atrium and left ventricular outflow tract. And here is the interventricular portion between the right ventricular inflow and left ventricular outflow tract. Look at this GIF images. It is a little fast, but I trimmed that part of the tricuspid leaflet, and the membrane septum is important because in its inferior limb, along its inferior limb, we can find the bundle of hairs like this way. You can notice how thin this is. In this case, it is almost 1.5 millimeter. And here you can see the window. I opened the window at the apex of the triangle cock. This is a compact AV node. So the key point is a little specific point. From this right anterior oblique direction, the so-called bundle of hairs looks like very long single strand. See? Very long single strand along with the membrane septum. But in fact, at the ventricular part, the wide, broad, proximal part of the left bundle branch is bifurcating from the distal part of the so-called His bundle. So it is actually a branching portion. Right? Originally, the Wilhelm His Jr. Defined the His bundle only indicating at the penetrating portion of the His bundle, which is before this bifurcation. So this is a 3D reconstruction of the histology. Here you can see the AV node. Here is the penetrating portion, and this is the attachment of the septal tricuspid leaflet. And after the septal tricuspid attachment of the septal tricuspid leaflet corresponding to the interventricular portion of the membrane septum, you can find the branching portion of the his bundle. So it is actually not a single strand here, right? You can see this kind of anatomy by a 3D printing I brought today. So next, I would like to focus on the RAO anatomy, which is most important for any invasive procedures related to the device implantation. So this is from the McAlpine textbook. And look at this GIF images. So I'm showing here the progressive dissections. And in this case, here you can see that wide and not so prominent septomarginal trabeculations here, not so prominent. And this yellow thing, seemingly replaced by the fat, is the moderator band directing to you. And it is connecting to the anterior papillary muscles, which gives the tendon to the septal anterior superior and inferior tricuspid leaflet. And finally, you can see the membrane septum here. And I would like to show this RV segmentation. This is the septal surface of the right ventricle. Here you can see very smooth part. Here is very trabeculated, and here is also smooth. So basically, the right ventricle is divided into 3 regions: inlet and apical trabeculation and outlet. So if we going back like this way, so this is also this case has not so prominent septomarginal trabeculation, and this is the short axis view of the moderator band. This is septomarginal trabeculation and moderator band. So the septomarginal trabeculation is located between the inlet and outlet. And moderator band, especially in its basal part, close to the ventricular septum, is located between these 3 regions. This is important because usually this apical trabeculation lesion is quite related to conventional device procedure, including microimplantation. So now you are the micro. So we are seeing from the tricuspid leaflet, moderator band is here and going into the trabeculation jungle, apical trabeculation jungle. And you cannot proceed anymore because you are going to perforate. So from these images, you can see that it's actually jungle, right? So what is this indicating? It is indicating that you cannot change the direction once you dive into this jungle, right? So if you are going into the lateral part of the apical jungle, just creating the clockwise rotation cannot make you move to the septal direction. You cannot pull back something to the inlet part to get out from this jungle and rotate and proceed. That is anatomically appropriate approach. And usually this septal part of the apical trabeculation is related to, device implantation, especially micra, right? And one more concept that is very important is safe zone. So from the first place, the main concept of the safe zone is that you cannot apply the fixed RAO angulation to obtain the end-phase view of the atrial or ventricular septum. It's quite variable depending on the patient's anatomy. So like my institution uses RAO 30 degree, my institution is 45 degree. It is incorrect. Adjust it based on the patient anatomy. Why? Because this is the AP view. This is the RL 50. This is the RL 30. Focus on this part, the right hand margin of the silhouette, which is left ventricle. Is the proportion of the left ventricle is changing during the RL angulation. So right hand margin of the cardiac silhouette is very the right hand. It is almost always is the left ventricle. And the proportion of this left ventricle apex it depends on the RL angulation for the case-specific anatomy. So I would like you to focus on two parts. One is this part. This left ventricular apex is not the right ventricle. Even this is in the cardiac silhouette.
20 minutes.
It's okay. And one more thing here, it is the RVOT. So the deep side of this RVOT, there's no left ventricle. It means this is not the septum. Right? This is above the septal margin trabeculation. So this is a medial free wall of the right ventricular outflow tract, which indicate the risk of perforation if you think this is a septum. This is showing the safe zone now in the LAO image, and we are going to the RAO image. So anything you are dealing with true ventricular septum should be confined in this area. Outside of this area indicates any risk of perforation. So this is the quite old example of not physiological pacing, just a ventricular septal pacing within the safe zone performed by myself. So you can see the distance between the right hand margin of the cardiac silhouette and tip of the active fixation lead. It almost corresponding to the 1 inches as evident by the height of the vertebral body. So securing this distance makes it much safer. Also, this is a biopsy. You can see the distance here. See? Otherwise, you are going to biopsy the free wall of the right ventricle like this. Why this happen? Because this is out of the safe zone. Right? It's very dangerous. And you can see here in the liver phase, it is outside of the left ventricle. Right? So this is perforation. Because this is very close to the left anterior descending artery, we would not like to pinch the left anterior descending artery. And why this happens? Because the free wall or apex of the right ventricle is super thin. So here, almost no myocardium, completely replaced by the adipose tissue. So you can never push here within the apical trabeculation jungle. So my goal today is at least when you are seeing the fluoroscopy or you are trying to do fluoroscopic approach by yourself, you can see fluoroscopy like this. You can see the location of each chambers in relation with the surrounding structures, including trachea or descending aorta. That is my sincere hope for today. And this should be very important because in the previous lecture, Dr. Tina and Dr. Kirsty, the reading of the X-ray is really important. So finally, with the 3D printings, if you see the RAO image, you can image like this way. So now we are launching the new textbook in HRS 2022. And some part of the three-dimensional printing will be available soon. So I really hope for the next time we can bring this kind of contents in free for every attendees with the help of Medtronic. So I'm gonna stop my introduction here, and let's start the hands-on session by separating into two groups. Thank you so much.
So maybe we can just, thank you, Dr. Moray. Yeah. So just two groups, like these three tables on one side and those three on that side. And then you'll direct us, Dr. Moray? Yeah.